So, change the topic a little bit as rheumatology for Ayurvedic doctors, not just the updates. I'm not going to talk, I first thought of updating, but then I thought, what is the point? That's what something which we should be doing to the patients, like what is a modern treatment for something, you know. So, that's not what you want. What you want is how to, which patients you should refer to us, which patients, in fact, we should refer to you as well. And so that, and then what is that you need from us, you know, that's all that I'm trying to cover. So we'll go on with the slides. I've just listed few conditions here. These are the conditions I would just like to briefly talk about, and it might not be holistic, okay, but all that I can think of I've written. And what I want to say is each condition. First, say for example osteoporosis, I want to say, is this something which, every topic I want to start off with saying that this is something which, as me, my opinion is whether I want to deal with it all by myself, which means all by allopathic doctors, or whether it has to be dealt by both of us, or whether I think it has to be dealt by just by you, you know. So there are certain things, because I feel that we do have limitations, and I always tell them it's not important what you know or what you can do, it's also important for you to know what you cannot do, okay, and there are limitations. Understanding limitation is very important than just knowing what is there, you know. So with osteoporosis, I have to say, I believe that both of us should be managing, okay, yes, both natural therapy and the allopathic doctors as well. On osteoporosis, again, several junior Ayurvedic doctors and the lay people do get confused with this terminology of osteoporosis and osteoarthritis. Sometimes, you know, lots of big stuffs, but actually simple things they just forget, you know, so they don't know. So osteoporosis is weakening of the bones. It does not mean there is any damage, okay, it's a weakening of the bones. So bones are, the quality and the quantity of the bone is actually less. That is known as osteoporosis. And these are all the terminologies which the patients are using it nowadays, so it's better you understand it, okay. So weakening will not actually cause pain that much, okay, that you have to understand. It's only if there's a damage you get the pain. So just if they say, lots of people come to you with a back pain and say, oh, young people will say, oh, my back pain is due to osteoporosis, and that is rubbish, okay. So it's not osteoporosis. You should clearly say that osteoporosis does not cause pain. But if you have osteoporosis, it means that you're at risk of having fractures, okay. So that is important, simple, but important for you to understand and explain to the patient as well. But lots of people, older people, because this is a condition of old people, so they will have osteoporosis and osteoarthritis. So they will have back pain, but they can also have osteoporosis. But you have to understand that, next slide please, the difference. So that's what I've said. It does not cause bone pains unless in later stages when the bones are so weak, they cause small fractures, small cracks. So if someone with severe osteoporosis who is bent like the lady I showed, I forgot to tell, that's the mother and that's the daughter, okay. So, and people, they say the bend in old age is considered to be normal, but actually it's not. Osteoporosis slowly, by causing microfractures, can actually cause a lot of bending and crushing of the spine. So basically whenever the fracture happens, which happens only in older age, then they can get back pain. Otherwise osteoporosis does not cause back pain. Another common mistake people do is young people saying that I have osteoporosis, okay. So literally premenopausal women do not have osteoporosis, okay. They just cannot get it, hormones protect them. Unless they're menopausal, they don't have osteoporosis, okay. They can get pain, damage, everything else, but not osteoporosis. And very old males, yes?
What about the women who have undergone hysterectomy or oophorectomy? Are they?
Yeah, they're considered postmenopausal, they are at risk. So if the ovaries are taken, then they are menopausal. So even at the age of 30, if they had both ovaries. Again, patients do mistake, they think hysterectomy alone, but as you said, oophorectomy also has to be done. Only then they are prone for osteoporosis in earlier age, okay. Yeah. So that is also very important, because several allopathic doctors, we do, not rheumatologists, but orthopedic surgeons do a mistake of doing a lot of bone scans and branding them as having osteoporosis. Even us, I'm not talking about Ayurvedic doctors, so many allopathic doctors at the age of 30 doing a lot of bone density scan, putting them on calcium, vitamin D and saying that they have osteoporosis. In fact, they have some other problems. So it is a disease of postmenopausal women and old men, okay, not young people. So you have to understand that, that is osteoporosis. Okay, next slide. And this is basically the definition for osteoporosis. This is the only definition we have till now. This is a quantitative definition. I've told you osteoporosis means weak bones both from the quality and the quantity, but there is no way we can assess quality. There's no proven way till now. So quantitatively, if you do a bone scan and if the score is T-score, which is a standard deviation score, is less than minus 2.5, then you call it osteoporosis. It's as simple as that. Okay, so that is the current definition for osteoporosis. So if the bone density scan, okay, the DEXA scan they say, and if you do it and if the T-score is less than minus 2.5, then it's osteoporosis. Okay, but you have to understand if the reason for diagnosing osteoporosis is actually to prevent fractures. It's not for anything else. And fractures are caused not just by osteoporosis, it's caused by so many other things. Okay, if your vision is, if you have a cataract, if you don't see well, or if you have carpets at home, you trip and fall, okay, or if your balance is affected, if your diet is not good, if you get headaches, if you get giddiness, all those things causes fractures, and osteoporosis is just one factor. And that is why I said this condition has to be managed both by you and us, because I believe that you are better in managing the patient as a whole, okay, looking at things holistically. We are more, even though we advocate we have to look at the patient holistically, but the trend is not that way. We are more going towards a pharmacotherapy way, okay, so that's the way we are going, yeah, and you are going more towards the holistic way all the time here. So, so all the factors have to be addressed rather than just giving tablets. So this is where I think we allopathic doctors are doing mistakes. Lots of people who they say, oh, you've done the bone scan, T-score is minus 2.5, you have osteoporosis, start tablets. Okay, that alone is not enough to prevent fractures and falls. And it doesn't help the pain if you treat for osteoporosis. So these are the tablets and the treatments used for osteoporosis. The commonest is alendronate 70 milligrams per week. These are basically the osteoporosis happens, the weak bones happens due to decreased bone formation or accelerated bone resorption, bone damage or resorption basically. Okay, so this is the reason but the treatment we have currently, the most commonly used treatment is actually, there's no treatment to build the bone. There is treatment, but that's not the first line therapy. There are only treatments to actually decrease bone resorption. So we are not actually building with our traditional treatments, only we are trying to decrease the bone loss. So these are all the treatments. What is attracting of all is, in our therapy here, is this IV zoledronate, which is given once a year. So if you have usually your old grannies, okay, at home who had fell in the bathroom, fractures or something, you know, so but they can't take tablets regularly, and again Indian patients are usually very against taking tablets regularly. So this is very interesting, this giving this one dose of IV zoledronate 5 milligrams once a year, okay, for 3 years or 5 years, actually is very effective in preventing the bone loss and also preventing the fractures and also preventing death, okay, by preventing fractures. So it's very interesting treatment which we have. But they all have some problems, okay, all our tablets do have some side effects, yes.
Is that for the resorption or the bone building one?
No, not bone building. It is also for inhibiting bone resorption, that's it.
It's only the resorption.
It's only the bone resorption, okay, yeah.
But how does it then be effective for the entire year? It's no release that is there, how does this?
Yes, yeah, you know, it goes and it's like a chewing gum, that's the way I always tell the patient. It goes and actually sits in the bone. So this injection when you give from the blood, it goes to the bone and it just stays there. It's like a cement to the bone.
So this is localized thing or it goes systemic?
Systemic. So you give it in the vein, through the blood it goes all over the bone, okay, it goes all over in all the bones and it sits there for 1 year, okay, and by sitting there it makes it stronger. Okay, so and it is effective. It's been proven that it's very effective. So that's why it's interesting treatment. Okay, yeah, but it does have problems sometimes it's GI problems, and that's all tablets. A few other issues, but I'm not going to talk about. The side effects are there, but usually generally not much. Next slide, please. The first line therapy for osteoporosis patients also includes taking calcium and vitamin D. This again is very much abused by our doctors, I have to say. Okay. There's no need for taking calcium and vitamin D in a premenopausal woman. Okay, you just have to give a dietary advice like what you do. Okay, what happens with us is everybody gets calcium and vitamin D. Okay, they come with pain. That's not the right thing to do, because there's more evidence now saying that if you give too much calcium, it causes increased chance of heart attacks and stuff. So please don't discourage if somebody is taking calcium and vitamin D in a younger age group. Okay. Older age group, yes, there is evidence that it does help. So in older age group with a proven osteoporosis, yes, you have to give calcium and vitamin D, tablet, injections or whatever. I'm not going to go in detail about the treatment, just the principles I'm going to talk. So I've stopped with the first line therapy, I've took away all the slides of second line therapy, but you have one good injections which actually builds the bone, which is parathormone injections. Okay. So that builds the bone, but for some reason it can be given only for 18 months. Okay, so if you give it more than that, then it builds the bone so much, there's a risk of bone cancer. So only for 18 months. And again, there are lots of people try it in a much younger age group itself, at the age of 55, postmenopausal, T-score showing -2.5, and they have money. Again, our doctors do a mistake like just saying, okay, take this bone building injections for 1.5 years, so. But the reason why you treat this patient is to prevent fractures, and fractures are not going to happen until they're 70 years old. So the benefit of giving these injections is only when you're a little bit older, okay? Because building bone for 18 months and maybe that will last for another 2-3 years is not enough to prevent fracture at the age of 75, okay? But if you have an old granny who fell, 80-year-old, fell at home, fractured hip, and then now hoping to walk and you have to build the bone, this bone building is very good, okay? But it is expensive, that's why it's not a first line. Okay, next slide please. So that's osteoporosis. Next is osteoarthritis, and crystals have said, okay, which is like gout and stuff. So osteoarthritis, this condition I really want you to treat, to be honest, okay? Really, we are not doing anything correct in our practice with osteoarthritis. So in fact, we don't have any good pharmacotherapy options. It's all very, without any evidence, it's all just marketed with so many, all this glucosamine, diacerin, jointase, this, that, and all those things are cartilage building, they call, literally doesn't work, okay? There's literally no treatment on earth which works for osteoarthritis. It's all a placebo treatment, okay? And for some reason in osteoarthritis, the placebo effect is significant, okay? You give them anything and say that this will help them, tell them 25% of them will get better. This is a fact in osteoarthritis. So, and all this treatment is no better than 25%. So which means we don't know whether it is just a placebo or it's real drug effect. So nothing works. If there is anything from your side which you think helps, if you do a trial and say that this works, more than 25% patients do get better, then yes, you should try that, okay? There's nothing really we can do. So osteoarthritis, as I've already said, means damage, not weakening. You see that's a cartilage damage, then the bone damage, okay, everything happens. Here the damage happens. So there's no medication to repair the damage process. Okay, so only thing we can offer is if it is damaged to an extent that it is limiting their lifestyle so much with a lot of pain at night, not letting them sleep, then we offer replacement. Okay, I always tell the patients that, see, if you get a cataract, what offer a cataract, it's something it's a degenerative process, cataract. The only treatment for cataract is cataract replacement, okay? There is no medications to the thing. That's the same with osteoarthritis. Currently, at least. There are so many trials, everything going on, but currently that's the thing. There's no medication which will work for osteoarthritis. And knee pain is such a common thing, but unfortunately we do not have a treatment, and that is the honest fact. Okay, the next slide please, yeah. What is important when patient comes to joint pain for any practicing person is you have to differentiate whether this is osteoarthritis or rheumatoid arthritis. At least for us it's very, very important, because we know in rheumatoid arthritis we can make a huge difference, and in osteoarthritis we cannot. Okay, so it's important for us to differentiate between these two, and what we rheumatologists are always obsessed about is the early morning stiffness, which I think if you are a musculoskeletal practicing Ayurvedic physicians, I think even you should be asking that, because that is as good as doing a blood test or any scans or whatever. So if they have stiffness in the mornings, which lasts for more than half an hour, after lying in the bed and then they get up, and after half an hour if they have stiffness, any place, it could be the hands, then it's rheumatoid arthritis. But if it's in the back, then it is again inflammatory back pain. So it just indicates inflammation. Okay, and inflammation is usually a bit more serious than damage, means it causes more damage, the inflammation. So that one question, basic question, it's something which I have asked almost 100% of the patients I've seen today. Okay, because that is very important for me. Sometimes even the blood test can be wrong. Okay, so if the early morning stiffness is more than half an hour, then we think it's inflammatory type arthritis. And then the rest is pattern recognition. Okay, that is also there. So regarding the distribution, see, if they have only knee pain, we think it's osteoarthritis. If they have the arthritis affecting the index and the middle finger MCP joint in the wrist and the PIP joint, then we think it's rheumatoid arthritis. So the pattern of distribution and the early morning stiffness is important to recognize. Next slide, please. So this is just few more slides for you to know what osteoarthritis is. The commonly you see here the medial compartment tibiofemoral joint. The joint space is narrowed. It's all whitened. In bones, in X-rays, if it's white, it is damaged. Okay, always white is dead bone. Okay, keep going. Next slide. That's the same again. The left hip, you can just see the hip joint space is not at all seen. It's all much more whitish. The right side is also whitish. Yeah. But there are lots of cystic changes as well. So severe osteoarthritis basically. The hip is totally gone. Here no medications can fix. They need replacement. Okay. Next slide please. Yeah. This is again for pattern recognition. The first CMC joint, what we call. Someone comes with pain there, the base of the thumb. That is osteoarthritis. Okay. It's not rheumatoid arthritis. That joint doesn't get affected in rheumatoid arthritis. One other thing, because interested in natural things, there's an evolutionary theory behind this arthritis, osteoarthritis. So osteoarthritis is nothing but an accelerated damage which happens slightly in a younger age. So the joints which are not very well developed evolutionarily. For example, this joint, the CMC joint, is almost a new joint which the apes did not have, because apes can only have to climb, so they only had flexion of the thumb. But we are the only people who count. That's why all our economics developed, maths. We do numbers and we do write. So that happened. That is a two unique function for human beings, which no animals can do, writing and counting. And the counting is what made us all develop. So, and that is happened because of this joint called first carpometacarpal joint. So that's a unique joint. So any joint which is unique, and similarly the neck also. The reason why lots of people get back pain and neck pain is because we are the only two-legged people. Okay, everyone else is four-legged. So we stood up. So our neck is not trained to stand, our back is not trained to stand evolutionarily. So these are all the places where you get osteoarthritis. So that is a pattern you recognize. So where evolutionarily it's new, it's not trained enough, if they get a pain in that joint, then it most likely to be osteoarthritis. Okay, next slide please. So this is a different kind of osteoarthritis where you get this Heberden's nodes and Bouchard's nodes. They are bony swelling of this DIP joint and the PIP joint. This doesn't go with evolution. This is very hormonal type. This is very common in a post-menopause, like immediately when the hormone, because in women's when they become menopause, the hormones dip from say 100 to 0 basically. That's why they get all these flushing symptoms and all those things. It's like push, suddenly it goes. So the body gets confused there. Not everybody, some people who are genetically prone, the body gets confused and thinks that suddenly you got old. Okay. It starts creating changes in some of the joints, like as if you're a 90-year-old. And then after some time the body learns that you're actually not old, it's just your hormones went down, and then it stabilizes. This is sort of a self-limiting process, but for the first 3-4 years when they get this pain in the hands, till they get this bony swelling, they'll have pain and then the pain disappears. So this is something which, you see, this is also osteoarthritis. Again, pattern recognition, that's why we got this. Next slide please. So this is all the management we have for osteoarthritis. Literally, yeah, nothing works better than this, to be honest. Okay, physiotherapy, exercise, weight reduction. So general thing which I'm sure you'll do better than me. Okay. Okay, keep pressing. Yeah, managements I've just listed everything else, but nothing works, to be honest. We are so desperate, we try everything, but nothing works. So you can just go to the next slide again. But don't forget that joint injection with steroids sometimes helps in very old people. Some people will have so much of knee pain in very old people, and all that they want is just make us walk a little bit, you know. And those patients you can inject with steroids, and not otherwise young patients. In fact, if you give more injection with steroids, it causes more damage paradoxically. But in old people who just say, I want to get out of my bed and go to the toilet, please make me do that. Okay, there you can do joint injections. Next slide please. Okay, next slide again. So that's osteoarthritis, and yeah, keep going. Yeah, okay, I've got everything. Yeah, what you should know is it usually will last for only 8 weeks. Yeah, the crystals briefly, yeah, that's the gout. Okay, acute gout, which sometimes rarely you get it. This is a pattern recognition. Young males who do drink also and suddenly trying to exercise, predominantly non-vegetarians, but also can happen in vegetarians if they're genetically prone. They're developing first, usually feet, but most commonly the first MTP joint of the feet is red hot and swollen. That's gout. You don't need any x-rays, you don't need any blood test, whatever. Okay, that pattern recognition you should know. This again you can treat. All your anti-inflammatories do work for this also. Okay, because it's a self-limiting condition. You really, without treatment also it gets better within a week or 10 days. So, but the pain is so much you need to treat. If not, they come in a wheelchair almost sometimes, you know. So yes, you can treat this with any anti-inflammatories. But if they have the same problem recurrently, if it's happening every 3 months, if it's happening every year recurrently, then I want my treatment involved. Okay, next slide please. So this is another type of crystals where they also get knee pain and swelling. It look like gout, but it will also be red hot and inflamed, but it affects the large joints like the knee, and what you see is all this white things inside the knee joint, which is a calcium crystals, which usually seen in old people. Okay, but the management is similar whether it is any crystals. Okay, next slide please. So the treatments, these are the treatments we use. From our point of view, we use this any non-steroidal anti-inflammatories, brufen, diclofenac, anything. There's also another drug called colchicine, which is traditionally from plants. Yes, yeah, okay. So, so that also works very well, equally well. We can try that. And then, but if it's happening recurrently, that is where you need to take more actions. There only lifestyle changes and weight reduction and stopping drinking and avoiding meat, all those things alone will not actually make a huge difference if it is happening recurrently. Okay, and recurrently means I would say 3 times a year. Okay, if it's happening more than 2 times a year, sorry, it's happening more than 2 times a year, then you have to be advised on this uric acid lowering agent, which is allopurinol or febuxostat. Next slide please. So this is, if you don't treat, you see if it's happening recurrently, and if you ask me like, okay, let me just give some anti-inflammatory Ayurvedic medications which just treat the pain each time, then this is what will happen if you don't treat. Okay, so all this uric acid will go in not only the joints, in the soft tissues under the skin, and will form nodules. I have one patient, like it's really the leg is like elephant legs, all because of uric acid crystals. It's got so much, okay, because his uric acid was not brought down. Next slide please. Yeah, next slide again. So these are all the gout. Tophaceous is gout if you don't treat the high uric acid. Next slide please. This is also tophaceous is gout. Next slide. Yeah. So and then that's the crystals. Rheumatoid arthritis. Okay. This is something, yeah, next slide. This is something which I really want to see. Okay, you have to give it to me. The reason being the advancement have been so much. Okay, I do make a huge difference to these patients. Okay, and I think if they try only Ayurvedic medications, they are doing mistake, is what my thing is. It's also because even though I don't know much about Ayurvedic medicines, what I also believe is, see the osteoarthritis, osteoporosis, gout also, all the crystal disease, they are all what we know is evidence-wise, we know is like there is an ancient fossils and even animals with all these conditions. Okay, so we know there's an ancient disease, and I can just believe that Ayurvedic medication, the people who were like long ago would have thought about it and done something about it or written something about it and everything. Rheumatoid arthritis, even as the modern literature, we don't have a single evidence of any patient with rheumatoid arthritis before late 17th century. And you know, like in Western world, like they were developed from 1500, you know, it's like American independence was 1787, whatever, you know. So they were all developed already, and if there was even one patient with a pattern of rheumatoid arthritis, it would have been documented somewhere in the world's literature, but there is nowhere. So till now what we know is rheumatoid arthritis, the earliest documentation, which is also in a painting version somewhere in the Madrid's museum, is actually in late 17th century. Okay, that is the earliest we have. But if you think of any other diseases, TB, it's described in Ayurveda by whoever, all those old physicians, and everybody has described about TB, everyone described about gout. Hippocrates described about gout in 2000, whatever, 2000 years ago, and all those things have been described. Somewhere or other we read that, but rheumatoid arthritis we have not. And another thing is, we can still say that maybe there are treatment for rheumatoid arthritis, maybe there's already, because there must be something natural already for certain conditions. But what I mean is, for the last 250 years, I think the research in Ayurveda has been zero. Okay, so I don't think so you will know. That is my guess. Okay, if you would have done a research in rheumatoid arthritis, and if you would have found out that, okay, maybe this combination is working for them, then it's fine. But in 250 years, it's been, with all the Western influence, it's been killed. There's no research whatsoever since this disease actually cropped up as a new disease in the society. And for that reason, I think it is, once you identify rheumatoid arthritis, I think you have to refer them to a rheumatologist. In fact, this is only one patient I want to see, okay? Because this is a very Western disease, lots of research has happened in rheumatoid arthritis, not in other conditions, okay, yeah. Because it's a very Western disease, it's a very big problem there. So there's a huge benefit in our treatments. So identifying early rheumatoid arthritis, I've already told you, is very important. which is basically early morning stiffness. I'm stressing again because it's important, and the pattern. Next slide, please. Treatment, I'm not going through in detail, this is just one slide. We have so many treatments, all these traditional disease modifying agents, methotrexate, sulfasalazine, hydroxychloroquine, leflunomide. In fact, we used to use gold injections, which I think you also have some gold products, you know, so we used to use all that. Excuse me. But the thing is, all those things we've stopped using it because of increased side effects. So only new medication, and the trend is more and more. If the cost is not a factor, the trend is more and more of using all this what I've mentioned in the italics, all this anti-TNF, anti-IL-6. These are the ones which are actually very, very effective. We are now talking. There's one thing we always differ from. Like, we don't say that we cure people, but in rheumatoid arthritis, we are talking towards near cure in these patients. I can tell the patients that you will be fine, you will be at work, you will not have any problems, your side effects will be minimal. I can tell that with all these modern treatments, and they do really work. Okay, they do work, they do wonders. Only the cost is limiting, and it's only because of the cost we are actually using the older drugs in some patients, and we don't really use all of them. In fact, hydroxychloroquine and leflunomide also, we don't use it that much. Only methotrexate and sulfasalazine, of which even sulfasalazine can go away, only methotrexate. So if you can try one tablet methotrexate, which will work in about 50-60% of the patients very well, and if they don't work, if they cannot afford, try other tablets. If they can afford, then actually going straight to the costly injections means you give them life back. Inflammatory back pain, again, I don't mind if both of us manage. Okay, you can also manage, and I can also manage. Depending on if it is too severe, maybe I would like to manage. Okay, if it is very severe arthritis or something. Next slide, please. Yeah. Again, early morning stiffness. So everyone has back pains. You know, like 80% of this audience will have back pains at some point. You know, so but if they have early morning stiffness for more than 30 minutes, then you call it inflammatory back pain. And in those patients, and if they have other features, you know, eye problems, eye inflammation, tendinitis, fasciitis, skin psoriasis, all those things, then it points towards inflammatory back pain. Next slide, please. These are all the conditions I've told you. We've been using reactive arthritis. We use the term reactive arthritis purely for this kind of conditions. It's a non-post-viral reactive arthritis is what we use reactive. Mostly bacterial. Post-bacterial arthritis is reactive arthritis with a large joint swelling here. A lot of inflammation and swelling will happen. They have these conditions. These 4 conditions are grouped together because they have this commonality. They're usually very genetic. They're all HLA-B27 positive, and they all have these other features. This is an ancient disease. This has all been, I know, ankylosing spondylitis has been described 2000 years ago. Okay, they even found a mummy in a British museum who had ankylosing spondylitis. You know, so it's all those things we know. These are all ancient disease, and I'm sure you will have some treatment for this. And here, there's also like we have no evidence that treating them very early, aggressively with our medications is going to have a huge impact. Okay, what we know is if we treat them, we change the outcome, we make them better, but there's no evidence that treating them very early with our medication is going to make a huge difference. Okay, because this condition is not that rapidly progressive. So here, I don't mind if the patient goes to you first, get your treatment, not better, come back to us, and all those things, it's fine. Okay, next slide, please. Right, and the next slide again, soft tissue problems, there is lots of them. Okay, go on, but I want to go region by region, briefly mention. Next slide, please. Yes, so shoulders, elbows, wrist, fingers, hips, knees, ankles, feet, and these are the common ones. There are so many other soft tissue, almost everywhere there's a soft tissue, but the common ones you see as a pattern recognition is rotator cuff tendinitis, where ladies typically can't do a bra or lift their hands and comb their hairs. Frozen shoulder, we call it capsulitis, and then elbow, tennis elbow, golfer's elbow, all these things I'm sure you'll also come across. In the wrist, classically, people who work at home a lot, who wash the clothes, they get this dequavin stenosynovitis, which is abductor pauses longest tendon inflammation. Trigger finger, you come across, these are also tendinitis. So these are all what we group together as a soft tissue problems. And for this, in fact, even you can treat, okay? We don't have much treatment for these things. We just use the simple anti-inflammatories, the same thing for everything, you know. So anti-inflammatories for most of them we use, but I don't see why your anti-inflammatories can't work as well. So you can try for all of these patients, you can try. But what we do, one thing extra is if the simple tablets don't work, next slide please, we do injections, local injections. So after ruling out injury, that's one thing. Okay, so because most of the time this could be due to, lots of times we assume that this is just tendinitis, but it will turn out to be like they had an injury actually, it's a ruptured tendon. Then if you do an injection, then you're actually causing harm. So like this, we also cause a lot of harm. So this is why That's why you always have to rule out injury. If injury is not there, then local injection is the treatment of choice. Nothing else works. But I have no problems in these patients if you manage them forever. Okay. Viral arthritis, this is probably the most topical and more relevant. You'll probably see, I was just chatting before, this post-viral arthritis, almost one of your family members would have had it recently, you know. It's just rampant, this post-Chikungunya arthritis. As I was telling, like, I'm not employed by Apollo, I'm employed by mosquitoes. These mosquitoes are paying me, you know, so they're causing all this arthritis. And almost all of them, I think is Chikungunya, okay. Almost all of them, okay. But you can call them as post-viral, as non-specific viral or Chikungunya-like illness. But I think it is just that because our tests are not improved enough, like in dengue. Dengue is a bit more talked about, a bit more researched about even in India, okay, even worldwide, okay. So there's something more, the tests are a bit more advanced. You know, when dengue, they do 3 tests, NS1, IgM, IgG, all those things they do. And they're aware, and there's some pattern recognition, everything is there. But in Chikungunya, there's nothing there, no research whatsoever, zero. Okay, there's literally nothing we know about it. So I just think the tests are not developed enough in anything, but I see a pattern, and all of them, 100% of my patients do get better. And I see the 100% of patients do have a typical pattern. The pattern is basically this high fever for 2 to 4 days with headaches, followed by joint pains. And one cardinal feature which I always confirm more than the blood is the leg edema. Okay, if they have swelling of the legs, even little bit, okay, because which not the arms or anywhere else. They can have joint pains in the hands, but they will have leg edema. I think it is because it's all mosquito borne. There's always an overlap between dengue and Chikungunya. There's overlap between the symptoms, I mean, it's overlap between malaria and filaria, okay, and all those things. So filaria is also mosquito borne. So this is also overlap between filaria and these things. I think, which is not proven, that this causes lymphadenitis also, okay, of the inguinal glands. So when you get a fever and everything, the lymph nodes also probably a little bit swollen up, and they get mild lymphedema. Basically, it's everybody gets mild lymphedema. In fact, that's the only thing. One question I ask. Okay, they come with joint pain and say, immediately after the fever, did you have leg swelling? You know, and if they say yes, I say you had Chikungunya, 100%. Okay, so that's a cardinal feature, and very rarely, there are few patients who've been branded as having amme, you know, the measles, they say, all this thing. That's also Chikungunya. They'll have widespread skin rashes also, but they'll have a lot of joint pain. Joint pain is always a feature, and that is also Chikungunya post-viral arthritis. And during recovery, they'll get better. The pain might get after the treatment, pain might get better, the edema can get better, but still for a few weeks, they might get a little bit of numbness and tingling. And this can happen in the feet and also a little bit in the hands. Okay, this is a pattern you won't find in any textbooks, because I'm seeing so many patients, almost every patient is having the same pattern. And if they're having so much same pattern, I think it's only the same virus causing it. Okay, if it's a different virus, there'll be slightly different pattern. Okay, so this is a classical pattern which all of them get, and they're all, I think it's a post-Chikungunya viral arthritis. And next slide please. What I do is simple. So the test you have to remember, commonly used test which you are just after Chikungunya test, they do only IgM Chikungunya, which is not so sensitive test, and that comes negative, and everyone shows me the report and says, sir, I've done Chikungunya test, it's negative, it's not that. I say, no, it's not a sensitive test, it's not useful. There's another test which only NIMHANS does, maybe other places do, but what we refer always to NIMHANS is PCR for Chikungunya, which is actually better, a lot better. So if I've done for 10 patients whom I suspect Chikungunya, 5 patients a PCR comes back positive. And in fact, 1 or even sometimes even less than 1, the IgM test comes back positive. So PCR for Chikungunya at least has come some 50% in my own numbers. Okay, so you should ask for that only. Okay, now to confirm it. And what I do is this one injection works. I am depemedrol 120 milligrams. That's all. Okay, and for some reason the solumedrol, the different kind of steroid, doesn't work. Tablet steroids are also not that effective. Other simple anti-inflammatory drugs like Brufen, diclofenac, naproxen, or maybe even your anti-inflammatory drugs do not work that well. They will feel better. They'll feel better. They'll say 10%, 20%. But if I give them one IM depemedrol 120 milligrams, 90% of the problems will go away the next day. And in more than 95% of patients as well. So almost there's been no patient who came back and said it didn't work to me till now. I've probably seen maybe hundreds, okay, just in the last year or so. So that is one thing. If you don't know why, maybe it's a long-acting steroid, the depot, it's a depot version. Solumedrol, other kinds of steroids are more water soluble, I don't know. Maybe it's not going into the joints that much or whatever, I don't know really. But it always works. So if you have somebody and all that they have to do is this, maybe you shouldn't do the injection yourself. That's why I was interested, you got allopathic section. You just say, go there and get the nurse, everyone I am depemedrol, they'll all be fine. Okay, I'm not even asking them to refer to me to you because that's all that I do. I don't do anything more than that. Okay, and they all do get better. But they do come back a little bit saying, I'm 90% better, 80% better, a little bit have numbness, tingling in the hands and feet. I told you that. That is the way it recovers. And you just have to reassure them that will also go away. You can give any tablets at that time if you want. Okay. So that's it. So next slide, please. Yeah. And finally, find the next miscellaneous condition. Next slide again. So this is something which is I really want you to deal with because I'm fed up of these patients. Okay. This fibromyalgia, but it's very common. In fact, it's as common as any other arthritis, osteoarthritis, rheumatoid arthritis, or everything. Yeah, this fibromyalgia is it is not directly a psychosomatic condition. Okay, it's not like they are mad. You can't call that. Okay, but this does happen in people with personality disorders, basically. So these are the people who have had serious problems in the past. Okay, not currently. They look very normal. They look very normal like you and me, you know, so, and they'll have good, see, because you can, any physicians, if you practice, you will know, okay, they have good eye-to-eye contact, they're talking to you, they're looking to you, they're asking, responding to your questions and everything. They're normal, they're not abnormal, they're not depressed or mad, but they will have pain problems, okay. You would have come across so many of your relatives having similar things. You would consider them as normal in the society, but they will always complain with pain. And that is because of past experiences, not currently. And everyone would have had bad past experiences, okay. But people who have an abnormal personality, and this is why your holistic medicine, your prayer, all those things are useful because then you develop a personality. If not, you end up having these problems later on in the future, okay. So if you have a good personality and if you try to fight against the problems in your life in a normal way and get out of it and everything, you won't have any problem. But these are the people who had problems when they had problems. And they'll otherwise be fine, but they'll end up having lots of pain problems, fibromyalgia. And this is important, and you tell this and explain to every patient you see who come with fibromyalgia, then almost everyone will be relieved. They think, oh, you are absolutely right. Okay, I had these problems those days. All these days I've been to 10 different doctors and they told me I have nothing and I'm mad, you know, but that's not true. Okay, that's right. Because there are separate psychosomatic conditions. There are people who are really mad and they tell you that I have problems when they don't have problems. Here they do feel the problems, okay, but it's just that you can't see it, okay. Again, the example it gives like a dentist, you know, you feel the swelling when you go to a dentist, but you actually don't see it, okay, because it's all in the nerves. So if the problem is in the nerves, then you don't actually see it. So these are problems in the nerves. It's actually, though the complaint of muscle pain. So there's some chemical changes happens or whatsoever. So it's a genuine problem, but it is due to previous personality thing. But the thing is that personality has not changed since then to now. So it's a very difficult patient to deal with, and that's why I don't like. Because if you speak to any psychiatrist, they will say like they don't mind treating with a psychotic schizophrenic people, but they actually have problems managing any personality disorders. Okay, somebody who is really angry, somebody who is really something like that, you know. So that personality disorders are very difficult to manage in our clinics when we are busy and stuff, when we have other priorities. So that's why I don't want these patients, okay, because we really don't have tablets for personality disorders, okay. So, but these are named as so many other things, ME, chronic fatigue and all those things. Next slide, please. So this is a diagnosis of exclusion. See, I've told you, if you can recognize osteoarthritis, if you can recognize rheumatoid arthritis, and if these patients have this other still whole body pain they'll have, again, not no region, whole body pain, and they have these trigger points. That's one thing we always check for trigger points, especially these two. If you press them, you complain of pain like that, you know, and they have this altered pain perception, which is an increased pain perception, what we call hyperalgesia and allodynia, which means normally a touch, if you understand physics, no, an input, you should get an output, okay? A touch stimulus should be felt as touch stimulus. These patients, a touch stimulus will be felt as a pain stimulus. So we call this altered perception, okay? They get this altered, they have fibromyalgia. And they have so many other problems, okay? They'll complain of everything. They'll complain of breathlessness, fatigue, this, that, and everything. You have to recognize these things and reassure them. Next slide, please. And I think here the answer is alternative medicine, because you do look at the patient holistically. You do treat so many other, and that is what these patients need, to be honest. And all pharmacology-driven practice, what we have currently, they're trying to come up with new tablets for this condition because it's so common. 1% of the world population have it, okay, which means very big number, okay, yeah, huge number. So they come with all new tablets, but nothing works, honestly. Nothing works, no tablets work, okay. But now explaining to the patient, understanding it, all that I've told you now, you tell the patient and make them understand the condition, reassure them they don't have any serious problems, treat them holistically, diet changes, lifestyle changes. sometimes even change a spouse, whatever. Sometimes the problem will actually be the other side, it's not her. So whatever it is, but that cannot be fixed by tablets or us. So all those things have to be recognized. And alternative medicine, as I said, any alternative medicine which I feel the patient believes in will work for them. Okay. If they don't believe in Ayurveda, whatever you do will won't work for them. Okay, next slide please. I think that's it. Thank you very much.